This is Bruce Lee's weekly town hall. We do this every Sunday at 4 o'clock. Today's featured guest is Dr. Denis Nash. He's an epidemiologist with the City University of New York. Without further ado, Grace, you want to get us started?
Yeah, thank you. Thank you, Dr. Nash, for joining us today. We were talking about the attendance and participation on these town halls, and I said there's a direct correlation between how nice the weather is and how many people we get on, despite social distancing and that sort of thing. But excited to have Dr. Nash on today. Dr. Nash is the Executive Director of the CUNY Insitute for Implementation Science and Population Health. He is also an epidemiologist with over 20 years of experience and leadership in conducting epidemiological studies. His central interests include infectious diseases, the field of public health surveillance, and the use of public health surveillance data to conduct rigorous assessments of programmatic effectiveness and the impact of policies on health. He has worked extensively in domestic and international settings, conducting large-scale, real-world epidemiologic studies, examining key outcomes among persons with HIV infection. So, I ran into Dr. Nash's work as my team and I were beginning to, as we have been thinking about policy, public policy from a public health perspective and how to, an economic perspective in New York State and New York City. And really excited to have Dr. Nash here today to present and to share his work with us. Just to kick it off, epidemiologists have become really, really popular all of a sudden. And so before we move forward, Dr. Nash, can you describe explain to us what an epidemiologist is and the type of work that you do?
Sure. So epidemiologists are experts in the field of epidemiology. We study the distribution and determinants of disease. At its heart, epidemiology is about understanding the causes of disease and the determinants of health in the population. And once we can understand what causes certain health outcomes, then we can go about the business of ourselves and our colleagues in other fields of influencing these health outcomes for the better. And so I think of epidemiology and what epidemiologists do as a central part of public health, in that it helps us understand what causes of disease and health are and how we influence them. If you think about, of course, we now know the cause of this pandemic is a virus, but in the very beginning, we didn't necessarily know that, but quickly it was discovered that it was a virus. Quickly it was sequenced, but the work isn't done there of epidemiologists. We need to go further and understand, well, how does it spread? The kinds of things that epidemiologists are concerned with, outbreak situations, but we also do a lot with non-infectious diseases, such as heart disease and diabetes and cancers, things like that.
Okay, great. That's super helpful. Do you want to? You created an amazing presentation. Really excited for you to present. Do you want to? Should we step right into it and go from there?
Sure. Thanks, Grace, and thanks for inviting me to talk to you and your group. And it's a great opportunity for me to share with other New Yorkers the kinds of work and science and public health that's going on at the City University of New York and our institute and our School of Public Health. And it's in this case, it's affecting all of us now in real time. And so I'm taking all kinds of opportunities to get out and speak to people about this work. So I'm just going to talk a little bit about the goals of the public health response to the COVID crisis, and also tell you a little bit about some work that we're doing at CUNY what we're doing for our part to try and contribute to the response to this pandemic. So one thing that I've been thinking a lot about since the beginning is how important the response to the COVID crisis and also future pandemics really need to be focused on the timely dissemination of goal-aligned metrics, and these should be common and standard across jurisdictions. It really does help us mount a more effective response to the epidemic. It needs to be nimble and effective to minimize spread and suffering and deaths. And some of these horrible socioeconomic and racial inequities that we've been seeing. But sometimes neglected is this notion of systematically gathering and disseminating, especially early on in the public health response, a well-chosen set of metrics that are aligned with the goals of the response. So what are the goals of the public health response? Just to pull back a little bit, what are we trying to do now that we have this horrible pandemic situation in New York and elsewhere? I would say that there are many goals, first of all, and I'm just highlighting 3 of them here that I think are particularly important. The first one is to mitigate, suppress, and control community transmission of the virus through physical distancing and other non-pharmaceutical interventions. This is not a pathogen that we have a vaccine or a treatment for, and so we need to resort to other modes of reducing transmission, things that we've been doing since the very early days of pandemics, and in 1918 for flu, for example, when there was no vaccine or treatment. Goal number 2, so goal number 1 is really about what public health needs to do. Goal number 2 also involves public health, but also connects directly to the healthcare system. It's about preventing or minimizing morbidity and mortality from COVID-19 disease. So first, we're thinking what the best way to prevent morbidity and mortality is to control and suppress transmission. But given that we have a lot of community transmission happening in New York, we also need to think about how we can minimize morbidity and mortality from the disease. And that is about having our healthcare system prepared to deal with the crisis as best we can, and learning as we go about how to better manage the cases of COVID that come through the doors of the healthcare system. And goal number 3 is about protecting the healthcare workforce and other essential workers from becoming infected with SARS-CoV-2. If we cannot protect our healthcare workforce and other essential workers, it's really going to be hard to make it through this. And this is something that I think where we fumbled a lot from the beginning, starting with lack of personal protective equipment and things like that. Our public health response should certainly have this as a key goal, because it is our healthcare workforce and other essential workers, first responders, people working in grocery stores, that are keeping things together and have kept us together over the last few months. And so we also need to think about metrics as we shift and shift into the next phase of the public health response, is thinking about how we reopen society. I'm not here to talk about how to do that. There's a lot of people thinking about this, and there are many ways we can move forward. But one thing that I will say as an epidemiologist is that we need to think about using metrics to guide this process. So first, along with other criteria, our jurisdictions need to specify in advance what are the thresholds for some of these key metrics and their trends that guide the decisions to reopen society, or alternatively to reimpose physical distancing measures when those need to be reimposed. These need to be specified in advance, and we can see examples from New York State in doing this. It's not happening everywhere across the country, but prior to reopening, we already are seeing our state articulate some of the criteria that need to be met before we can move into the process of reopening society. So the routine metrics and dissemination of routine metrics to all who need to know, which I think, and who are in a position to act and deal with the response to the epidemic, which really means everybody. We all have a role in mitigating this pandemic. Metrics are key, and getting people on the same page and knowing where we are and where we're going is critical. And I think New York City is doing a better and better job at getting the right metrics out there so that people can see where we are. There's also a role for, I think, more in-depth epidemiological work, and this is what I call observational cohort studies. So this is not the routine kind of data and epidemiologic work that governments would do, but more like agencies like the CDC or academics to put together cohorts of people and follow them over time to get a better understanding of the natural history of the infection, to get a better understanding of the extent to which public health measures are being taken up and whether they're working at reducing transmission risk. And so these include asking questions like who's most affected and at risk, what is the impact of implementing or relaxing some of these different non-pharmaceutical interventions like physical distancing. And we want to understand how, not only how they influence outcomes related to the virus, but also some of the other things. I mean, this is a pandemic and a response to the pandemic that has really transformed life across the country. And so it's important to also be thinking about psychosocial outcomes like mental health and social support and interpersonal violence. We also have some key epidemiologic questions that aren't really quite fully answered yet. Like, among those who are infected with SARS-CoV-2, what proportion are asymptomatic? This is an important estimate that is very useful to inform some of the mathematical modeling activities that we're constantly trying to refine so that we can get a clearer picture of what is going to be happening under different scenarios as we begin to reopen society. Another key epidemiologic question is, among those who've recovered from SARS-CoV-2 infection, if they have antibodies to the virus, is there short or long-term protection against reinfection and or development of subsequent severe COVID disease? This is a critical policy question to ask because it really does inform, which options there might be as society begins to reopen in many places around the country. And of course, there are other opportunities to learn more about this pathogen and other like host-related factors that may influence outcomes. And so this is the sort of context that was that we were all considering at the CUNY Institute for Implementation Science and Population Health when we decided, when we sort of got together from our various homes because we were all physical distancing. What should we do as an institute? That is, our theme really is about trying to identify ways of improving population health through better implementation of things that of interventions and policies that we already know work. It's not about trying to find the vaccine or the new cure. It's about trying to figure out how to do what we know works better so that we can influence population health. And what we came up with was the idea of launching a national cohort study. And so we conceived of the Chasing COVID Cohort Study. We set up a website and an opportunity to join the study right here. We launched this on March 28th when there were about 500,000 cases, about 700,000 deaths. We also put ads on social media like Facebook and Instagram and Scruff where people could see these ads and click through and join our study if they were interested in joining a study. We did tell people that that our intent was, it was really too early to say if we could do this, but our intent was to be able to offer serologic testing to our participants if a good test became available and if we could get funding to cover the costs. So we then proceeded with the process of enrolling. This was right during the upswing of the COVID pandemic in the US. You can see here the death trend in the US in the dark blue line here, alongside our enrollment trends in light blue. So we were enrolling people in our cohort right as the pandemic was taking off across the US. At the end of enrollment, we were able to enroll about 7,000 people. from across the US, and they're coming from all 50 states, DC, Puerto Rico, and Guam. So it's a geographically diverse cohort. And if you overlay this map on the left of our cohort participants with some of the hotspots of SARS-CoV-2 in the US, you can see that we've enrolled people from areas where there is active SARS-CoV-2 transmission in our cohort. And I'll just blaze through some of what we've found so far based on the baseline enrollment characteristics of our cohort. About 23% of them are age 60 or older, 25% are non-Hispanic, Black or Hispanic, 16% unemployed, 47% have incomes less than 50,000, 39% are coming from urban areas, 54% fall into a category that I would call high risk for severe COVID-19 outcome if they were to become infected. So this has to do with age, it has to do with underlying health conditions, and also smoking. And importantly, 38% of those in the younger age group here, 18 to 48, fell into this category. So it's not just a cohort of, it's not just older people that are at high risk for a bad outcome. Younger people can be as well. About 9% of our cohort are healthcare workers, and 5% are, and 18% are industry. We also asked the cohort about some of the different they have taken part in that either governments are urging citizens to do, or they decided to do themselves to protect against SARS-CoV-2 infection. And you can see there was pretty high uptake of some of the things like avoiding large gatherings, avoiding handshakes. And we asked people about whether or not they were experiencing COVID-like symptoms prior to the baseline enrollment, and about 20% said that they had experienced COVID-like symptoms like cough, fever, or shortness of breath. And of those with symptoms, about 60% were at high risk for severe disease. 39% said they saw a healthcare provider, and 12% were reported having been hospitalized. And looking across the entire cohort and thinking about testing, 5% said that they had gotten a SARS-CoV-2 test. About 8% said they tried to be tested, but they couldn't get a test. And ultimately, about 2.7% reported a COVID-19 diagnosis. So this is, this says that this is a group of people that is at risk for SARS-CoV-2 infection. It also says that there are still many that are likely at high risk going forward when we begin to think about opening up society. I mentioned that we also asked about mental health and depression, and this is a slide just showing what we learned about, that we deployed a scale to measure anxiety symptoms, and about 37% of our cohort reported symptoms that were consistent with moderate or severe anxiety, which is really quite high, understandably, because of what was going on. And when you look at how the prevalence of moderate or severe anxiety, the line here going across is showing what it was for everybody in the cohort. But if you look at some of the different groups in our cohort, frontline healthcare workers obviously had much higher anxiety levels. People who had symptoms or had an actual diagnosis or were hospitalized also had very high levels of moderate or severe anxiety. And also those who had a loss of income or needed care but couldn't access it. So anxiety and other mental health outcomes are a significant challenge and burden of people in our cohort as well, as we would expect, given everything that's going on with this pandemic. So that sort of describes the baseline characteristics of our cohort. We're moving into the follow-up period of this cohort. So month one, we've already contacted everyone in the cohort to complete the next assessment, and that includes us sending a a dried blood spot specimen collection kit to their home that we will then store with our lab and ultimately do serologic testing on. But we'll be following people forward in time, and we'll do another serologic test in late July. And again, maybe if we can get funding to do it, one in October 2020. And we may even decide to follow the cohort out for much longer than October. This is the kind of, there's so many unknowns about where this is going. And so we will leave the door open to continue to follow this cohort for longer periods if we need to. This is a slide just giving you a sense of the kinds of things. I've already covered some of this, the kinds of questions that we've been asking people. This is what we asked at baseline, and we've added a number of different things in the follow-up. And we have the ability to be nimble and add questions about what we think is important to learn about. For example, in the month 2 follow-up survey, we'll be focusing on expanded testing and contact tracing, among other things. To give you an idea of how the specimen collection works, we mail this kit to people's homes along with this instruction flyer here that tells them how to do it. Before we rolled this out, we did a small pilot in some of a few of our cohort participants, and they get this kit in the mail. It comes priority mail. And there's instructions in there how to do it, and they fill out, they use a small lancet to prick their finger, and they leave 5 little dried blood spots in a card, and they mail it back to us in a biohazard envelope to the lab where we're storing it for subsequent serologic testing. So this is sort of where we are. You can get a sense of what we're learning so far in this national cohort. We recruited them rapidly during the upswing of this pandemic, while our team at the CUNY ISPH were all socially distanced, and we were doing it during the upswing of this pandemic from one of the world's epicenters. It's a really remarkable accomplishment, and I'm very proud of the team that we were able to pull this off. But what we know is there's so much that remains to be learned that can inform the public health response to the current pandemic, including, how well the response is going, where there may need to be course corrections, if it's having the impact we intended to, about this pandemic, but also a lot to learn that we can use to inform the response to the future pandemics that we know it's not a question of it, but when they occur. So I'll stop here. I want to acknowledge the Chasing COVID Cohort team. They did such an excellent job at being responsive and finding, all of us getting together to try to find what it is that our team could bring to the table here to add something to how we could learn about this pandemic and help out. Also, people in the School of Public Health Research Office at CUNY, the CUNY School of Public Health, our Dean, Ayman El-Mohandes, and our laboratory. I'm happy to take any questions and engage in a discussion. I just want to say that there's so much that I'm sure everyone wants to know about this pandemic, and I cannot by any means answer all of those questions. There may be some I hope I can answer, but there's so much that any one person I think would have trouble answering all the questions, but certainly do my best, and probably between me and others on the call, we'll at least be able to find out where to get the answers to some of your unanswered questions.
Great. Thank you so much for this presentation. It was really informative, and it's nice to see that there are so many great minds working on how to, bring more information to the table about this disease. I wanted to start, one of the goals that you mentioned early on in the presentation is to mitigate, suppress, and control community transmission. And a lot is being talked about right now regarding testing and contact tracing. So can you, for those who are not as familiar with contact tracing, can you talk about what contact tracing is, and also how you believe it could be implemented for COVID-19 in New York City to help, stop the spread of the disease?
Sure. Okay, so contact tracing is a core public health strategy that is used to respond to many, but not all, communicable diseases that where there is an intervention that is effective at reducing spread when you identify someone who's newly diagnosed or newly infected. At that time, what you do is you talk to the person who's newly diagnosed and understand from them what kinds of contacts they may have had during the period where they may have been infectious, so that you can reach out to those contacts and make sure that they're aware that they've been exposed, and any public health response that needs to happen there can happen. In the case of SARS-CoV-2, this is the public health response for those individuals is quarantine, and also maybe testing of them and following them forward in time for the development of symptoms. So this is a method of containment, and the response to the persons who are found to be infected is isolation. They're placed away from others so that they no longer continue to be at risk of infecting others. So this is it's a disease control and containment strategy. We've seen it used for other illnesses, other infections like tuberculosis. When Ebola was happening around the world, a key strategy for containing Ebola was contact tracing and isolation and quarantine. But also for sexually transmitted infections and including HIV, it's a key component of the public health strategy to contain and control these epidemics. For SARS-CoV-2 and how we'll move forward here, this testing and contact tracing was a early part of the response in many places. In New York City, when we started to do this, it became clear pretty quickly that community transmission was very widespread. And when community transmission is very widespread, contact tracing becomes very infeasible to do because there are too many people with a new diagnosis. We've had situations where there have been thousands on a given day in New York. And the number of contacts that all of these new cases have, makes it that much more challenging. Imagine, 5 or 10 or 15 per case. But when we begin to drive down new infections and new diagnoses in New York, the way that we have been, we do begin to be able to move back into a phase where we can implement a testing and contact tracing strategy. We need to be able to expand testing, which we've been challenged doing. And we also need a lot more people who can do the work of talking to new people who are newly diagnosed and then reaching out to their contacts and doing what needs to be done from the public health standpoint. And that is the reason why there's an effort to hire many thousands of contact tracers to do this kind of work. But it is a strategy that people will, that jurisdictions will use to basically control and slow the spread of SARS-CoV-2 going forward.
So when do we get to a point, do you think we're at a point now where we can implement contact tracing effectively to begin reopening the economy? I mean, at what number of cases do we need to see in New York before we can kind of think about that without overwhelming the system? And do we have enough professionals to even start doing this type of thing?
Yeah, maybe I'll just start there. I mean, we could think about expanding testing for sure in this city if we had the tests and the capacity to do that. And I think it's increasingly getting closer to that. we do not yet have the capacity to do the contact tracing work. I think the city intends to hire, you know, a first tranche of about 1,000 or 1,500 people in the coming weeks, and maybe a few thousand more after that. I mean, to give you an idea, in Wuhan city, where the epicenter of the pandemic to begin with, they had about 9,000 people doing contact tracing work there. And so no, we're not at a place where we can do the contact tracing yet, and the strategies and the actual approach that the city will use to do it is still sort of being worked out. And I think yeah, so we're not there yet. We could be doing it if we had the people and we had the testing, but it's a slow start.
Actually, it looks like Sari's got a question. Hold on one second. Sorry, I'll unmute you.
I think Cuomo said today that there's going to be 2,300 people doing contact tracing.
That's the number I've heard. I don't know if it's going to be enough. But.
I grew up on Christopher Street in the 70s and 80s. They've been doing this contact tracing for VD for a very long time. Why is it only now being thought of? Is it just because there was just too much, there was overwhelm for the people who were following VD cases to do it? I mean, there must have been a department of this kind of thing to begin with, no?
Yeah, there are many people at the health department that do this kind of work every day for sexually transmitted infections, for HIV, for tuberculosis. The number of cases that they need to trace and do partner notification for is manageable compared to SARS-CoV-2. You know, we're talking about maybe 2,000 HIV diagnoses every year in New York City, but with this outbreak, we're talking about, you know, thousands of diagnoses a day. So the scale is just completely different.
And yeah, I'm glad we brought up some of the sexually transmitted diseases that, that we've had to face in New York City too, and tracing those. I think there's a lot of concern about privacy and sharing personal information. Can you speak to that? I know you have some kind of thoughts on whether we are risking, oversharing as a result of, doing this work with contact tracing, and also people's willingness to do it.
Right. Well, I can say that, this is something that's gone on for decades, as Sari said, in this city for other conditions. And the people that do it are at the city health department are seasoned professionals, and they know how to do it discreetly and by protecting people's privacy, and also, not making it feel intrusive. Like I said, though, it's never been done at this scale before, and we're going to have to hire people who don't really have experience doing it, and so there has to be a lot of attention to training folks so that they can do it the right way that it's supposed to be done, protecting people's confidentiality and privacy, making them feel respected, and getting the public health job done.
Great, and I think Chris had a question. Go ahead and unmute you.
Okay, first, happy Mother's Day, everybody. Everyone who's a mother, and doctor, thank you for being so gracious with your time, sharing this information with us. My one question is, you talked about how robust spending would have to be to get contact, or what was the term that you used?
Contact tracing?
Contact tracing, thank you. With contact tracing, wouldn't there be a need, or rather, isn't there a necessity to have some sort of technology on the back end and front end for the government to support those tracers? In other words, if you don't believe that there's enough bodies, an estimated 2,300 is enough bodies just for the city, and Westchester and Long Island alone, then like what kind of technology would be needed in order to self-police and to ensure that like the right numbers are coming in?
Yeah, I completely agree that technology has to be part of at least part of the solution here, but I'm not so sure how much technology the city is planning and the state are planning to leverage to do this. So I think that I think that there's no way that they can really do a fully successful job without leveraging some kind of technological solutions to help in the process. Not only because there are so many people that have to be reached and a lot of information gathered from all of these people, not just once, but maybe several times for each person over the period of say 14 days. It's a lot of phone calls to be making by a lot of people, to a lot of people in order to have that happen. But also the process of just trying to locate people. When someone who's newly diagnosed tells you that they have had like 3 or 4 contacts over the last few days that should be reached out to, they may be too sick to really give you all the contact details. They may not even know all the contact details. So sometimes what the information they provide is like a name and maybe like a neighborhood or something like that. And so for that, you really need to, I think, leverage technology to try to find, narrow down, and find the best contact information for people. Otherwise, it becomes a very frustrating job of getting a lot of names and not being able to find anybody.
Okay, thank you. And then I guess one quick follow-up. So that being necessary, when we talk about reopening non-essential businesses, Lower East Side, Chinatown being small businesses, mainly service restaurants, things of that nature, would it be safe to support an opening of these small businesses without that kind of technology, without the proper contact tracers?
I don't think it's safe to do it without expanded testing and contact tracing. I think it is probably going to happen without technology. That seems to be where it's going for New York. But no, without some kind of strategy to do contact tracing and expanded testing, it's not safe. That's a prerequisite, in my view, for opening up society.
Thank you, Grace.
All right, we've got a question also from Sarah. I'm going to unmute you now. Go ahead, Sarah.
Hi, thanks for this presentation. It was nice to see an epidemiologist speaking on this. I was wondering just logistically what it would look like to hire this army of contact tracers. Would this be a job where you would need the training that current contact tracers have, where you need maybe a bachelor's degree training in healthcare? Or is this something where we could train someone who maybe had a role in a different industry and wants to become a contact tracer? What does that look like? What is that training like? And how long would it take to get someone up and running to where they can go and do the work that needs to be done?
I do think that that you can train people from all kinds of other fields to do this kind of work. It doesn't have to be someone who's trained in healthcare or even someone necessarily with a bachelor's degree, but they do have to have the right curriculum to train people, and they should be trained by people who are very seasoned in these kinds of activities. But you can imagine people from all kinds of different industries that could bring useful skills here. People skills are really important. I think the ability to understand. There's a need to understand the core concepts of what's behind contact tracing, why it's being done, how it works, the ability to have conversations about sensitive issues and medical issues with people, and the need to be discreet and keep things private when having these conversations and when interacting with other people about their work. But I think there's lots of opportunities for people from all kinds of different backgrounds to be trained to do it.
Thanks. There's some questions in the chat now. What about using new technologies for contact tracing, such as a phone app with a decentralized solution to address privacy concerns. This is the way other jurisdictions approach this issue, such as Switzerland.
Yeah, I'm really intrigued by these approaches. I do think there are ways to do it while protecting people's information and keeping it confidential. And also, I think what I've heard a lot of the experts in privacy discuss in this country is that it has to be an opt-in thing. And so if that's true, if for the US, it has to be an opt-in, unlike other places that have implemented some of these technology solutions. It's been sort of mandatory, like you can't move around unless you show that you've engaged and are clear from a health standpoint to move around. So if it is going to be an opt-in kind of solution to use some of this technology, then I think that there needs in order to get as many people as possible to use it, they need to be incentivized, and it needs to be worthwhile to use it. And so that's a design challenge that I think is an interesting one, where there's a chance for people to be, creative and make this as useful as possible.
And also on technology, there's another question. Apple and Google formed a partnership to use built-in health systems in phones for contact tracing. Do you think that is going to be an effective solution?
Yeah, I think so. So as I understand it, I'm not a software app specialist, but as I understand it, Apple and Google have developed components that could leverage some of the information in people's cell phones to let them know if they've come into close contact with someone that has had a SARS-CoV-2 diagnosis during the time where they may have been infectious, and that they're leaving it up to software developers to use these things to develop apps that leverage them to work. So I'm sure we're going to see some of these things cropping up if they haven't already.
Okay, great. Does anyone have other questions in the chat? So it sounds like for us to even begin to consider reopening, we have to have a much more widespread testing, and then we need a much larger kind of group of people, contact tracing experts and teams of people who can get out with the technology. What kind of timeline are we looking at here for even a modest reopening for certain, maybe more essential businesses?
For the contact tracing, you were breaking up there for a little bit, but what kind of timeline do you need for contact tracing to get to reopen?
Yeah, from where we are currently to, how many more, what do you think the timeline is for us to kind of get to a place where we can start to reopen?
Well, for the expanded testing and contact tracing, the timeline is yesterday. Like we should be where we should have been in a place where we could be doing many more tests than we're doing now, and we should be having hired and trained a few thousand contact tracers to start doing this work, but we're not there yet. So even if we did have those in place yesterday, I still think the city is in a place where there's such large numbers of people in hospital and ICU beds that it would be, from a public health standpoint, dangerous to think about reopening society, because the concern would be that the healthcare system could get overwhelmed pretty quickly. And so there needs to be some time to allow these physical distancing strategies that we've been suffering through for the last few months to work a little bit longer. And I have heard I've heard anywhere from 1 to 2 months, depending on whether it's the governor or the mayor, in terms of like how long we're going to be in this situation. I mean, that could always change, but if you look at some of the core metrics that I was alluding to earlier, the trends are all going in the right direction, but the number of people in ICUs are still too many to think about this for at least several, I don't know, like a month from now would be my guess. But all this is not going to be decided just by public health and epidemiological considerations. So, and there can be, phased openings of different things. And I know that the governor has talked about, doing different things for different counties, depending on where they are. But it sounds like New York City is probably going to be one of the last places of the state to get there. I don't know, Grace, you may have a better sense of what some of the political leaders are saying about this than I do.
No, I know as much as anyone else watching Cuomo's conversation. So it's helpful to get at least some benchmarks for what we need to see before we are able to really have confidence that we can get up and running. Because sometimes, that hasn't necessarily been clear from our elected officials as to what exactly needs to get done in order for us to do that. Can we think really quickly about herd immunity and this idea that, at some point, maybe enough people will have had it that, it will be less infectious?
Yeah, so that's this is one of the reasons why, not the only reason, but one of the reasons why we want to know if having antibodies to SARS-CoV-2 confers immunity to subsequent infection and disease. If it does, and especially if it does over the long term, then we could imagine getting to a place where enough people have antibodies who have been infected in the past that it really does limit the ability of the virus to spread around in communities. Right now, it can sort of spread in an unfettered way. There's not much immunity at all in the population, and so it just tears through. But when you reach a certain level of immunity, like I think some of the estimates for this particular virus is upwards of like 67%, then you begin to move into a situation where spread can actually decline on its own, just due to immunity in the population. But we don't yet know the answer to that critical question of whether or not the infection with the virus confers short or long-term immunity.
And you talked a little bit about the psychosocial outcomes of the policies that have been put in place to help contain the disease. Can you speak a little bit more to what other things that we really need to be thinking about, concerned about when it comes to public health as we apply these policies of sheltering in place and et cetera?
Yeah, well, I mean, I think I alluded to some of the big ones. I mean, one thing that I've been thinking a lot about is how, first, just the devastation of and the fear associated with, the pandemic, and let alone like you or your loved ones becoming infected and very sick or hospitalized or dying. That has a direct effect on mental health. But in addition to that, there's all these other things that are having an impact on people's mental health, like losing jobs and income and things like that. And so this in turn has its own effect on mental health and well-being. And not only that, these income loss and job loss are not happening evenly. It's affecting some parts of society more severely than others, and so it's going to worsen disparities in mental health outcomes over time. So that's something I've been thinking a lot about, and anything that drives mental health outcomes is also going to drive things like alcohol use, problem drinking, and substance use, which in turn have their own challenges, and poverty. I mean, this is a direct cause of poverty, you know, in the city and all around the country. And so and I mean, just even thinking about how it's going to affect the city alone it's just, there are so many dimensions that are not, you know, directly related to the infection that we need to be thinking about, and we're trying to anticipate the kinds of questions we want to ask our cohort participants so that we can, you know, really understand and, you know, hopefully raise awareness about some of the important issues that public health and governments need to be attentive to, because the number of dimensions of life and well-being that this pandemic is going to negatively affect it is really, really big.
Great. Is there, I think there are a few callers on the line. Does anyone, if you're on the phone and you have a question, you can dial *9. We'll just give you a few seconds if you're interested. In the meantime, there's one more question in the chat. With the research on COVID changing so quickly in the medical community, what's the best way to stay up to date with what researchers are finding out about the virus? It's a great question, Sarah.
I think it depends on how much of a junkie you are, and how much you like to be a consumer of like raw research. If you really like to be a consumer of raw research, then you know, there's a service called medRxiv, medrxiv.org, where a lot of scientists are publishing preprints of their work before it undergoes peer review, and you're seeing a lot of journalists cover this kind of work too. But this is where you can learn about some of the latest science that is being produced, you know, really quickly. If you're maybe less into the, you know, the details of individual scientific articles, I think some of the leading medical journals like JAMA, you know, do nice summaries that are of the science that are pretty accessible. I've been finding the New York Times. I binge on the New York Times stuff every morning, and they do cover a lot of the relevant science I found.
Okay, great. Al, are there any questions on the line? No, we're good. Okay. Well, Dr. Nash, I just want to say thank you again for your time today. This was very informative and really gives us a picture of how we move forward from here in New York City. I'm, you know, cautiously optimistic that, you know, we can start reopening the city sooner than later, and certainly with research by people like you, we're going to get closer to doing that and maintaining, you know, being able to contain the virus. So thank you for your work and your time today. And,
okay,
you know, we'll stay in touch.
Thank you. Thanks for having me, Grace.
Before we end the call, and thank you, Dr. Nash, and thank you, Grace, for hosting these weekly town halls in order to help spread information to everyone. I want to remind everybody, Grace is running for Assembly. We are still having a primary election. It is June 23rd. Be sure to vote, everyone. It looks like the Board of Elections is sending out absentee ballot applications to everyone this year. We don't have any information about specifically when those are going to be sent, but we do encourage you to fill those out if you don't want to go to the polls on Election Day. If you would like to vote in person early, you should be able to go down to the Board of Elections 2 weeks before the election and fill out a early vote, or you can go down to the Board of Elections and fill out an in-person absentee. Those should be available at least a month before the election. So all of that coming up soon. Otherwise, polling location, June 23rd. Vote for Grace Lee, running for Assembly. Again, thank you, Grace. Thank you. Anybody has any final thoughts? Speak now. Hearing none, great. We'll do this again 4 o'clock. Be sure to follow Grace on social media, Grace Lee for NYC on Facebook, Twitter, Instagram. If you want to volunteer and help with the campaign, you can find her website at graceleeforassembly.com. That's Grace, L-E-E-F-O-R, assembly.com. Thank you all so much.
Thanks, everyone. Bye.
Bye. Thank you.